And next talk is changing track a little bit, and I will get I get Sar Basra to present the next speaker. Thank you.
Okay, hello. My name is Sarb. I'm a social worker at Fraser Health. Now that we can see each other a little bit better, for most of us practicing in healthcare and renal services, we have some idea of what other disciplines do, but perhaps not all the specific details of each other's professional responsibilities. As social workers in healthcare, our roles are often a bit misunderstood by patients and families, and also by our interdisciplinary colleagues. So I'm quite pleased that we are able to share a little bit more about renal social work practice, so you're able to better utilize social work support for your patients and teams. In the busyness of renal units, social workers often end up spending a lot of time dealing with transportation, finances, housing, and referrals to community services. Social work is more than handy dart and transportation issues. We all work in a medical system which often holds high values on quantitative measures such as lab work, diagnostic testing, financial efficiencies, formulas, and numerical values and outcomes, even though we've had some wonderful presentations today. While these are all essential to the provision of good medical care for our patients, they alone are incomplete in helping our patients' overall well-being. There are also many coexisting psychosocial and spiritual needs which require more qualitative interventions and perspectives. It takes time, skills, special knowledge, and patience to listen to the complex stories, private struggles, hopes, and needs of our patients and their care providers. We cannot separate the science and art of renal care, as both are interconnected and both are required to help our patients. And it is quite refreshing that in many of our presentations today, there were more and more of patient experiences integrated in our practice. And I think Mike also touched on some of those issues that we need to do more of that as well. Social work practice provides a compassionate, ethical, and systems lens to our patients' journey through their illness, disabilities, various dialysis modalities, transplantation, end-of-life care, and bereavement transitions. Here to shed a little bit more light on our current renal social work practice in BC is my colleague Bobbi Preston from Abbotsford Kidney Care Clinic. Please welcome Bobbi.
So one of my nursing colleagues has animated my my PowerPoint, so I think that means I need to get kind of multitasky up here, because I've also got a couple of other presentations today. I've made some notes, and just those are in an attempt to make sure that we don't end up on some other topic. Which is just this? The green one? Big green one in the middle. And where do I see the screen to know that it comes up? I just have to look over the side? Oh, there it is. Okay, so we're good. Is it going? Sure. Okay, so this particular presentation, and I'm going to stick to my notes, is intended to raise awareness around the competencies, the scope of practice of the renal social workers in BC. While the social worker role is being highlighted, this is in context actually of profound respect and appreciation for our colleagues in the other professions, and a commitment to an interprofessional team approach for collaboration and outcomes that are in the best interests of our patients. We acknowledge that everybody here has a commitment to quality care for renal patients, including patient representatives, the Kidney Foundation, staff at every level in the health authorities, our nephrologists and all the partners, in the renal program, and of course BC Transplant and the BC Renal Agency. So social worker has 4 syllables, so yeah, it's going to sound a little repetitive maybe in spots, so please bear with that. Little technical difficulty here. So I think I'll start off just by telling you that RSW, an RSW is a member of the British Columbia College of Social Workers who holds a certificate of registration. So that was just to clarify that when we see RSW, we're not talking about renal social work, although we do renal social work. The R stands for registered, just as the R in RN stands for registered, and the R in RD stands for registered dietitian for people that are accountable for their practice and to their colleges. Although social work is a long-time profession, until the 1960s, social work was an unregulated profession in BC. Interestingly, the first BC Social Work Act exempted social workers who worked for ministries, such as the Children and Family and healthcare, from actually having to be registered. So in 2008, the BC College of Social Workers replaced the Board of Registration. So at this time now, social workers in health are now required to be registered and accountable to the public and to their colleges for their practice. They are required to take standardized examinations for their levels of qualification, and the national and the international standards for renal social work is a master's of counseling, of social work. According to the Social Work Act, I'm glad I had my notes, aren't you? According to the Social Work Act, social work means the assessment, diagnosis, treatment, and evaluation of individual, interpersonal, and societal issues through the use of social work knowledge and skills, interventions, and strategies. And those are both clinical and non-clinical, and across numerous domains. Clinical practice refers to the professional application of social work theory and methods of treatment and prevention of psychosocial dysfunction, disability or impairment, including but not limited to emotional and mental disorders. So social work assessment is the process of determining the nature. No, it's broken down here. It's not. Oh, it will work up here. I just can't see it. Okay. All righty. So I think I've said this. Okay. Social work diagnosis is a series of clinical judgments based on social work knowledge and skills. So that would be with couples, families, and groups. That is from which is the basis for the actions that social workers take or they don't take. And that's based on social work code of ethics and standards of practice. In primarily health and mental health settings, the diagnosis refers to the physician determining and identifying a specific physical or mental or emotional disorder or condition. Our diagnosis is very, very much different from that, and we clearly do not want any confusion around that from other professions or even from our own. Some social work practitioners aren't comfortable with the term social work diagnosis, and they will use the term clinical opinion. So according to the legislation, though, a social work diagnosis is related to social and psycho-emotional realities in the realm of social work expertise, and a clinical opinion, though, that the professional social work is actually held accountable for. So in healthcare, social work addresses the social and psycho-emotional functioning of the person in the environment and informs the psychosocial model of care. It's not an adjunct to the patient or the team. It is a specialized lens looking at the issues in order to partner with the patients around understandings and implications, and in order to provide the more complete medical picture for the healthcare team. Especially in chronic disease such as renal, the medical reality very much becomes a predominant aspect of the person's environment. The role is facilitating integration among the patient system, the renal system, the healthcare system, and at times other systems. Renal social work cannot be done in isolation without a working knowledge of the patient's medical situation, or it would be like attempting to put together a puzzle without important pieces. Likewise, research in healthcare demonstrates increasingly the value of interprofessional providers working together to understand total health and the medical picture, and why there is an interprofessional approach so that other healthcare providers aren't trying to put the puzzle together without important pieces of the picture missing as well. So also with regards to isolation, social work should not be practicing in isolation either, apart from social work practice leadership, to consult with appropriately and in order to keep practitioners grounded in the profession. So under the surface, in renal, social workers are focused on the psycho-emotional aspect of diagnosis, illness, and treatment of chronic disease and end-stage kidney disease. Social workers are actually obtaining renal-specific certification, for example, in the United States, where the practice is still a bit ahead of ours, but that's not happening yet in BC. We provide initial and ongoing assessments. And this isn't a question of fact-finding around social data, but clinical judgment about assessing in a way that provides relevant data. Our patients have strengths and potential vulnerabilities. Ongoing requirements of collaborative treatment decision-making along the disease trajectory, and social work provides assessment, consultative and direct services related to cognitive decline, anxiety, depression, caregiver burden, and other assessments. We assess health literacy with regards to interpretations, constructed meanings, and implications. And we provide therapeutic interventions, individuals, couples, and groups. These are brief, they are targeted, they are designed to support the goals of the our patients and to support the goals of the renal program. We mediate conflict between patient's primary support system, and the healthcare team. We support goals of care by enhancing the problem-solving capacity and facilitating positive changes in management styles. And we refer beyond our scope for further assessment to physicians or to other services or programs. We have mandates per adult guardianship, mental health, child protection, and other relevant legislation which is needed when we're managing complex patient situations. And within the healthcare system, we are the designated responders. We also provide resource counseling and resources in the community. So the theme of this conference is transitions. We have transitions at diagnosis, at change in stage, decision-making, dialysis starts, renal transplant, addressing end of life, and palliative care. The role is involved in transition planning and psychological preparation for transitions. People can experience challenges to one degree or another along the renal trajectory, especially at important junctures. We are focused on the bigger picture and long-term consequences of the change process, rather than looking at the short-term, acute, and medical needs. And there was a segue with our last speakers about even diagnosis, the underlying cause of the kidney disease, can indicate some of the unique issues people may need to address. For example, managing other comorbidities, another comorbidity on top of other comorbidities. That has implications as to how people respond to diagnosis and how they begin to assimilate that into their next steps. Dealing with the trauma of a health crisis, such as a cardiac arrest and ending up on an acute parachuted-in dialysis without any psychological preparation. Each person, in context of their support system, needs to be assessed individually with regards to how they're managing their diagnosis and when and who in the family would or may benefit from assistance in processing that information and getting it into a perspective. People with polycystic disease very often have loss and grief issues, high symptom burden, numerous social issues related to family members, and uncertainty regarding themselves and all their feelings about the fact that this is genetic and how that may or may not impact their children. Psychonephrology differs from psychonephrology is different than psycho-oncology, but our patients or their loved ones who have walked through the cancer experience, it could be another complicating factor for them in terms of adjusting and resolving their renal reality. The cancer story may be a separate story for them, or not a separate story for them. Whatever concerns them is the most important thing that needs to be addressed if it's going to interfere with their ability to hear what the healthcare providers have to say, enter into thoughtful decision-making regarding their own lives, and adjust and have good outcomes. And social workers don't attend to stories just for the sake of hearing stories. People will tell stories for lots of reasons, because they're simply anxious or have unresolved issues that they continue to be ruminating on, or as an avoidance tactic, because it's an easier story for them than the one that they think the renal team may be trying to tell them. Social work has skill in advanced communication that is intentional for assessment, and to cut to the chase and assess what the underlying and salient psycho-emotional and social issue is that requires an informed response, rather than get caught up in conversations that aren't going to be helpful for the patient. Treatment decision-making is a recurring ethical consideration throughout the renal trajectory. Social work co-facilitates education and psychoeducation related to options, treatment options, along with nursing and nephrologists, and is got a role in ameliorating the distress related to medical education. What is medical information at one level is actually going to become day-to-day activities of daily living for the people that we work with. Social work is really concerned with autonomy and capability as a human rights issue, and informed consent. Oops, I don't know how to go back. There we are, okay. We review a person's social and psycho-emotional readiness for transitions regularly, and we provide clinical counseling for them and their support system related to transitions. So what does that look like in action? Here are only a couple of examples in relation to patients, the interprofessional team, and the renal program. And social workers present case studies differently than nephrologists do. But anyways, in any case, so 30-something-year-old gentleman with previous separate pancreas and kidney transplants, and previous and retransplanted pancreas transplant, followed by the post-transplant program in Fraser Health, and again going into renal failure without a living donor. PD is presumed the next best options given his age, and he's perfect. He fits all of those criteria, to which he actually consented to before he was even referred to Kidney Care Clinic for monitoring and options education. Apparent to social work during the options education was that he was disassociating. He had a long, complicated hospitalization at the time of the failed transplant. He was in isolation for much of that time. He'd experienced a few hallucinations. He'd been seen by psychiatry, but without a definitive diagnosis. And on discharge, he'd had no mental health follow-up. Although he did qualify for persons with disability and was working part-time, and he was functioning reasonably well in the community. He's screened in by social work assessment as anxious and by the BC Renal Agency guideline for anxiety and depression. So social work referred to mental health, and he didn't follow through as he had not followed through previously. He had increasing interactions with the healthcare system over the next couple of months due to diarrhea and dehydration. He left the ER a couple of times, as well as an acute care hospital admission. In social work follow-up, he reported he was having anxiety attacks with every interaction with the lab, with the renal team, with other medical appointments, and every time he learned that his eGFR had changed. Another referral was made to mental health, for with each drop in his eGFR, he had become increasingly challenged with managing in the community, and work and housing became unstable. So, social work documentation, it demonstrated the psycho-emotional and social deterioration in direct relation to a failing transplant and dropping eGFR and increasing encounters with the healthcare system. Renal social work spoke then to mental health, advocated with mental health, given a now psychiatrist diagnosed PTSD related to health issues diagnosis, for our patient was not following through with mental health because the mental health appointments were triggers for panic attacks and PTSD. Social work helped mental health understand the seriousness of the situation and the urgent need for enhanced levels of mental health support at this transitional time with PTSD increasingly exacerbated with every step closer to renal replacement therapy. Mental health responded and assigned a community health worker, and with observing him more closely, actually understood the level of assistance that he needed, and they immediately helped him with stable housing. So social work initiated a KCC case conference that included the patient, the nephrologist, the mental health case manager, and the outreach worker. The renal pharmacist was brought in for, given the extraordinary challenge of anti-rejection drugs, high potassium, and challenging anxiety symptoms interfering with medication management, so that this was first simplified for him, but it also initiated a therapeutic relationship with the pharmacist that would be involved going forward, because this is a gentleman that needed to be desensitized to what was a direct trigger and a reliving of his previous experience. Also invited to the case conference was the hemodialysis patient care coordinator. The case conference was facilitated with intentional use of language, structure, and timing, and designed for desensitization and therapeutic relationship building with the renal team going forward. With looking below the surface of a consent for PD as the treatment plan that seemed to make sense on paper and wouldn't have flown, and the potential for a health crisis and visits to ERs and leaving against medical advice, a solid transition plan was put into place to support a planned start and to avoid further re-traumatization, potential avoidable health crises, and associated costs, and with a client-centered approach that supported a young man's unique needs. And he made a very good adjustment to transition and is very likely still going to be a fabulous transplant recipient option in the future. Okay, another scenario. Renal social worker assisted the team in understanding what the devoted parents of a young woman with a rare physical and developmental disorder was struggling with. These were exemplary parents, committed caregivers of their daughter living at home. Social work triaged the initial appointment so that it was with the parents only. As parents, they were willing to do anything for their daughter. Mom was willing to donate a kidney if that's what would be helpful for her daughter. Responding to the mother's willingness and questions regarding transplant prematurely with a referral to transplant, prior to this couple being able to kind of fully communicate and be in agreement with next steps would have been a very exacerbating problem for them. 2 minutes. Okay. They needed detailed information about what their daughter would encounter, given their expertise about what would be tolerable or intolerable for her in terms of pre-transplant investigations, ongoing blood work, how many people that she'd be encountering within the healthcare system. They needed a process to share profoundly deep thoughts that seemed unspeakable. The physical or the medical feasibility of a transplant were secondary to them. They had been living with physical and medical realities and managing those well since their daughter had been born. Our patient in stage 5 kidney disease was a tiny, beautiful little person in a child's wheelchair. That was a complicating layer for our healthcare team members who were parents of small children themselves. The parents, on the other hand, wanted to separate out the parental role and make the treatment decision that would be most ethical and respectful of their daughter's wishes, whether their daughter had parents or a potential donor or not. The daughter had turned 19, and they were no longer acting as parents with regards to our parents' healthcare decisions, and they were just so well aware of being temporary substitute decision. They knew that, before I didn't have to introduce that, they knew that. So I'll quote from the EMR, we don't call it EHR, we call them EMRs. This couple has done due diligence in exploring options for their daughter with respect for her not being able to articulate her wishes. Their devotion has been evident throughout the decision making. Mom reports they have heard her voice and have come to the decision for palliative care. They have come to agreement that even lab work for this particular individual takes an emotional and physical toll that impacts the patient's functioning. She is most settled when not exposed to alternate caregivers. Mom is an RN, and the family is hopeful their daughter will remain in the home rather than have hospitalization or hospice, but have access to support at home. So the family, including the other children, spent the last few weeks of her life spending time together and on vacation and visiting extended family without having blood work or any other intervention related to their daughter's health until the comfort care that was required at the very end. They gave their appreciation to Kidney Care Clinic. I'm going to go 2 minutes over time. So a young man, because it really relates to our last speaker, who had lost a parent and another family member to PKD, attended with his wife to KCC for an interprofessional appointment. It became apparent that beyond the concern that we often encounter on admission, that there was an additional layer that the young man's husband had not told his wife of his knowledge of his PKD. So the overriding concern in the room was a young woman wrapping her head around the fact that her husband had a serious disease, that she didn't know what the implications were for her unborn child, an additional layer of feeling kind of betrayed. So the fact that his eGFR was at 35, those were things that could wait for another appointment. If we really wanted to have them hear about diet and be able to land on their feet and be able to start moving into looking for other kinds of solutions, we needed to address the elephant in the room. The underlying nature of many matters for social work are often barriers for treatment, decisions, and adjustment, and are most often not obvious elephants in the room and fall under the radar, comfort level, and specialized skills of some of our other team members to address. The cases just described didn't involve referrals to social work from another professional, but came out of social work assessment. One more paragraph. So of course, we also receive and make interprofessional referrals as well. With social work, the presenting concern is often an obvious symptom expressed when the underlying concern isn't going to be put on the table without a therapeutic approach. Or perhaps there is no concern and we just encounter significant strengths. Please just refer to social work if you think it's indicated. The most important piece related to how parents respond, or patients respond to social work referrals has much to do with how that's introduced and how well the role is understood. We can be constructing confusion for the patient as to the value of seeing a core member of the team if we frame it as optional. The healthcare provider providing the services is responsible for explaining their role and obtaining consent for services. And advocacy. Social workers are on the team to fill a gap in perspective. Sometimes our social work perspective does not fit with the dominant perspective on the team. It's our professional obligation to provide a professional opinion. And sometimes the patient isn't always aligned. And we actually have, according to our code of ethics, recognize them as a core member of the team that bring expertise and an obligation to advocate for them at the front line and other levels. We also underpin and support the practice and the ideas and try to even resolve conflict when our patients are having issues with another healthcare provider. So, kind of didn't get to the total end of this, but please know that this is done with a view for best practices together at teamwork. And when we talk about, I'm on a great team, but when we talk about having healthy, vibrant, productive teams, a lot of it has to do with role definition and role clarity, and that's the attitude for which that this was presented. Okay,